Peace. Hi, it's Ronald. Welcome to the YouTube live book reading, Clinical Application of Respiratory Care. We are in the second chapter. Yay! Second chapter. Peace. Welcome. Welcome, YouTube. Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. All right, so we pick up at page 38, cardiac arrhythmias. Cardiac arrhythmias are significant only in relation to their potential deleterious effects on the mechanical functioning of the heart. When monitoring the electrocardiogram in a critically ill patient, there are three major areas of consideration in the classification of cardiac rhythms. 1. The origin and rate of the rhythm. 2. The presence of any enhanced focus of automaticity competing with the basic rhythm. And 3. The interference with propagation and conduction of the impulse through the conduction system, conduction defects. This simplified classification of basic cardiac rhythms will be discussed in three major categories. 1. Rhythms of supraventricular origin. 2. Rhythms of ventricular origin. And 3. Rhythms occurring in the presence of conduction defects. Supraventricular rhythms, figure 2-7. Normal sinus rhythm is the rhythm found in healthy, normal people and is characterized by a proper sequence of activation of the atria and ventricles in a perfectly normal conduction system. The rate in normal sinus rhythm is between 50 and 100 in adults. The term sinus bradycardia is used when the ventricular rate is less than 50, but the origin and conduction of the beat are otherwise normal. The term sinus tachycardia is used when the ventricular response is greater than 100 per minute, and the origin of and conduction of the beat are normal. A situation called sinus arrhythmia occurs when there is a regular variation in the rate of sinus beats, a variation characterized by an increased rate during inspiration and a decreased rate during expiration. Sinus arrhythmia is commonly present in children. And here's figure 2-7. So you can see at the top it has the normal sinus rhythm, then the sinus bradycardia, and then the sinus tachycardia, and then the pop. These are the model rhythm strips illustrating cardiac rhythms originating from above and ventricles in acutely ill patients. Thank you for reading books with us. Highest Heart Love. Clinical application of respiratory care. by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. Second edition. Thank you so much. Peace, Anthony and Bernice. Hi, it's Heart Love. Thank you for being here. Thank you for the likes and subs. We are pushing towards 500 subs, so keep sharing. Thank you so much. Happy August, everyone. Atrial rhythms are characterized by abnormal P waves. The origin of the beat is not the sinus node, but somewhere within the atria. A single beat from within the atria arising earlier than the normal SA beat is called a premature atrial contraction, or PAC. When this atrial beat When this atrial focus gives rise to three or more beats in a row occurring at a rapid rate, the rhythm is called an atrial tachycardia. A rhythm with extremely rapid atrial activity is called atrial fibrillation. Fibrillation. AV nodal or junctional rhythms originate from the area of the AV node. It was a first believed that the AV node was the actual origin, but this has subsequently been disproved. These rhythms are now referred to as junctional in origin. When this type of rhythm occurs, the atria are frequently depolarized in a reverse or retrograde fashion. Therefore, the P wave often has a deflection opposite to that which would have occurred normally and is sometimes lost in the QRS complex. We're at the middle of page 39. Thank you all for being here and reading with us. Yay! Thank you so much. Clinical application of respiratory care. Master material right here so that we can help others that we love and, give them insight. Thank you so much for being here. Ooh. Ventricular rhythms. Figure 2.8. Ventricular abnormal beats originate from some focus below the AV node and are characterized by a widened and bizarre looking QRS complex. The T wave deflection is in the opposite direction to the major QRS deflection. In general, these beats are indicative of a severe state of physiologic stress. If the ventricular beat occurs prior to the expected time of a sinus beat, it is referred to as a premature ventricular contraction or PVC. The frequency of these beats can be related to the severity of the physiological stress. The term ventricular bigmini is used when an abnormal ventricular beat, PVC, is coupled to a normal sinus beat. There may be several areas within the ventricles from which these abnormal beats are originating. If this occurs, the abnormal QRS complexes are different from one another. These phenomena are referred to as multifocal premature ventricular contractions. This is indicative of an even greater degree of physiological stress. If these processes are allowed to continue, a situation referred to as ventricular tachycardia may eventually occur. This is defined as the ventricular rate of greater than 100, with all of the beats originating from the ventricles. By definition, three or more ventricular beats in a row are defined as ventricular tachycardia. The major concern with ventricular tachycardia is that it can quickly deteriorate into a state called ventricular fibrillation. In ventricular fibrillation, there is no longer any coordinated contraction of the ventricles and thus no mechanical output of the heart. This is immediately life threatening and requires external cardiac massage and electrical defibrillation. Bing! There it is. All right, the bottom of page 40. Well, here's figure 2.8. The model rhythm strips illustrating cardiac rhythms originating from the ventricles. Normal sinus rhythm is shown for reference and comparison. So the normal sinus rhythm is at the top, and then the PVC, then the ventricular Benjamini, and then the multifocal PVCs, then the ventricular tachycardia, and then the ventricular fibrillation. Thank you so much for reading books. In this corner of YouTube, we read books, learn from masters, and master ourselves. Here's this masterful book called Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout, the second edition. Thank you so much. See that? At the top is the normal, and then the PVC going on. Okay, so conduction defects. Technically, a conduction defect could occur anywhere along the entire conducting system. In respiratory care, we are primarily concerned with conduction defects interfering with the function of the ventricles. The interference with conduction at the AV node is referred to as AV block. A first degree AV block can be thought of as requiring a prolonged time for propagation of the impulse through the AV node. This is seen in the electrocardiogram as a prolonged PR interval. However, every single beat is conducted into the ventricles. Further progression of the abnormality results in a second degree AV block, in which not every supraventricular beat is conducted through to the ventricles. The final degree in this abnormality is when none of the supraventricular beats are conducted through into the ventricles, a phenomenon termed third degree AV block, complete heart block. This is very bad. Thank you so much for being here. Awesome. This is so good, right? Yeah, mastering ourselves. It takes this. That's what it takes. To master thyself is to go in deeper than you've gone before. And that's what we do on this channel. Master ourselves. Thank you so much for being here. All right. So, this is seen in the electrocardiogram. Yes. Stimulated at their own rate. The atria in this situation are stimulated at their own rate. This basic rhythm is termed an idioventricular rhythm, and the ventricular rate is very slow, 30 to 50 per minute. All right, moving on. The middle of page 41, cardiac mechanics. The heart is functionally two pumps that are subject to the basic laws of mechanics. There are numerous physiological variables determining how effectively the heart will respond its workload. Extreme simplification of this complex subject results in two major factors that affect mechanical function as long as myocardial oxygenation is adequate: fiber length and fiber contractility state. Very key. Within limits, the greater the initial fiber length, the greater is the muscle's ability to shorten. That's right. This means the muscle has a greater compatibility of contracting against a greater force. The individual cardiac muscle cell fiber lengths must increase as the blood volume in the ventricle increases. The most important ventricular blood volume is that which is present at the end of the diastole. Functionally, the greater the end diastolic volume, the greater the ventricular muscle's ability to contract and pump at the necessary volume. Of course, this mechanism has limits beyond which it can no longer be regarded as a compensation. This relationship of heart muscle function with respect to end diastolic volume and ability to pump is called the Frank Starling relationship. The capability of a heart muscle cell to contract against any given load can be compared by using the contractile state of the muscle as the theoretic zero load. Positive entropism refers to an increase in the contractility state. Negative inotropism refers to a decrease in the contractility state. Positive entropism can be related to certain physiological phenomena as adequate tissue oxygen supply and appropriate acid base environment. Pharmacologic agents such as calcium ions, digitalis, epinephrine, and norepinephrine can also create a state of increased inotropism. The net effect of these changes usually results in a greater volume output in a shorter period of time. Top of page 42. Thank you so much for being here and reading with us. Beautiful. Negative inotropism usually results in less volume output over a longer period of time. It is caused by such pathophysiologic factors as hypoxia or acidemia, hypercarbia. In addition, the pharmacologic agents such as prop- propan- propanol, a beta blocker, anesthetic agents, and some pharmacologic antiarrhythmics can cause negative inotropism. Considering the overall function of the heart as a pump, the changes in ventricular and diastolic volume and its effect on the stroke volume can be expressed in a concept known as preload. This can be thought of as an initial loading force, and it is influenced by such factors as 1. Circulating blood volume, 2. The state of venous tone, and 3. The state of contractility of the ventricle, and 4. The mechanical restriction to inflow. Another factor affecting the heart's performance as a pump is the force against which the heart must work. This is commonly termed the afterload. The ventricles pump against a mechanical impedance, which is a function of both compliance and resistance properties of the vascular system and any mechanical restrictions to outflow. All right, moving on. The vascular system. Circulation can be defined as the dynamic process of circuitry circuitous blood flow through the heart and blood vessels. The necessary energy for this process is derived from the heart. The vascular system may be considered as having two major subdivisions, the systemic and the pulmonary circulations. The systemic circulation starts from the aorta, output vessel of the left ventricle, and ends in the right atrium. The pulmonary circulation starts from the pulmonary artery, output vessel of the right ventricle and ends in the left atrium. Each circulatory system is composed of arteries, capillaries, and veins. Arteries are conduits that carry blood away from the heart. Capillaries are vessels in which gas exchange takes place, and veins are conduits that collect blood from the capillaries and carry it back to the heart. Ding! The arterial systems are composed of a main artery, the aorta or pulmonary artery, which branches into large arteries, which subsequently branch into smaller arteries, which eventually branch into arterioles. The arterioles are the major resistance vessels. The arteries function as the major conducting vessels, and the arterioles regulate the distribution of blood to the various capillary beds. Highest heart love, pushing plant base, goddess Clarice. Highest heart love, happy Friday, happy August. Yay! Oh man, we're at page 42 down at the bottom. Thank you so much. In cardiovascular anatomy and physiology. I know it's so good, it's so deep. The arteries function as the major conducting vessels, and the arterioles regulate the distribution of blood to the various capillary beds. The capillary beds are the portions of the circulatory system where gas exchanges, respiration, takes place. This gas exchange in the systemic circulation is called the internal respiration, exchange between tissue and blood. The gas exchange in the pulmonary circulation is called the external respiration, exchange between blood and air. The capillary bed is a complex network of vessels and is referred to as the microcirculation. The flow within the capillary bed is primarily regulated by, yes, metatarioles, blood vessels, channels containing muscle tissue called the precapillary sphincters. It is these sphincters that control the actual distribution of blood flow within the capillary beds. Certain capillary channels within the network receive a more consistent flow and are commonly referred to as per- preferential channels. True capillaries are believed to be vessels without muscle tone, existing solely to allow gas exchange. Unlike the arteries, the veins are capable of large volume exchanges without great changes in pressure. Thus, they are called the capacitance vessels, the initial collecting vessels, or venules, join to form small veins, which in turn join to form larger veins. The large veins join to the join to form the major veins leading to the heart, the venae cavae, and the pulmonary veins. The venous system is capable of changing muscle tone within the vessels. The greatest percentage, up to 70% of the total blood volume, is contained within these, yeah, capacitance vessels, the underlying their important role in circulation. This is so good. Oh my goodness. Okay, I'm going to pause right here and we'll be back. We'll come back to page 43 in the middle when we reconvene. Thank you so much for this book reading. Clinical application of respiratory care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. We are in the second chapter. Thank you so much for reading with us. Highest Heart Love. We made it to August. Much love to all the book readers. Man, I love y'all so much. Mm. Oh, that's so good. I love you. Love water for the people, for my body. I want y'all to have a wonderful evening. Thank you so much for reading books. Thank you so much for the support work, likes and shares. We are moving towards 500. Peace, Goddess Clarice. How's your August starting? We got a full moon coming up, right? I know. I know. Thank you so much. Man, I honored y'all. Thank you for honoring me. Highest heart, love. You have a wonderful evening. I will talk to you soon, okay? I love you. You know I do. I'll talk to you soon. Peace, peace.